Episode 20, A Sprinter with Thigh Numbness. Welcome to Sports Medicine Case Studies, where I review published case studies in sports medicine. Okay, here we go. 14-year-old male competitive sprinter who presented to a clinic with a 3-day history of numbness over the right anterolateral thigh. The symptoms developed immediately following a running competition at his school. Of note, the patient had been evaluated in the emergency department on the day of injury. An AP radiograph of the right hip was obtained and interpreted as unremarkable. He was subsequently discharged without a specific diagnosis. Upon presentation to the clinic, the physical examination revealed mild tenderness localized to the region of the anterior superior iliac spine. Sensory examination demonstrated paresthesias over the right anterolateral thigh with diminished light touch and pinprick sensation in this distribution. Straight leg raise testing was negative. There was no pain elicited with passive or active range of motion of the hip joint. The patient ambulated with a mildly antalgic gait but reported only minimal discomfort. Okay, here's my differential. Number 1, hip strain. Number 2, meralgia paresthetica. Number 3, an avulsion fracture of the pelvis. Number 4, lumbar spine pathology. The clinical findings were consistent with involvement of the lateral femoral cutaneous nerve, a presentation known as meralgia paresthetica. However, the acute onset in the context of athletic activity warranted further investigation. I want to recognize the authors, Dr. Hu et al. This case study in the Journal of Rehabilitative Medicine in 2014. Okay, I'm Scott Hall, sports medicine physician, and I'm studying for my sports medicine certification exam in 2026, and I hope you'll join me on the journey. This podcast is for educational purposes only. Given the clinical suspicion for an underlying structural injury, the examining physicians proceeded with MSK ultrasonography. Imaging of the right inguinal region was performed. In the transverse plane, a mixed hyperechoic and hypoechoic hematoma was identified medial and inferior to the anterior superior iliac spine. It was located beneath the internal and external oblique abdominal muscles. The hematoma measured 3.8 centimeters in diameter and demonstrated no internal vascularity. When the transducer was oriented along the axis of the sartorius tendon, a separated bony fragment with minimal displacement was visualized at the inferior aspect of the right anterior superior iliac spine. The fragment measured approximately 1.6 centimeters. These ultrasonographic findings were subsequently confirmed with CT scan of the pelvis. The CT scan demonstrated an avulsed bony fragment at the inferior portion of the right ASIS with minimal displacement. Additionally, a region of increased attenuation consistent with the hematoma was identified approximately 1 centimeter caudal to the fracture plane. To further characterize the neurologic injury, nerve conduction studies were performed 10 days following the initial injury. Motor nerve conduction velocities of the bilateral perineal and tibial nerves were within normal limits. Sensory nerve conduction studies of the sural and superficial perineal nerves were also normal bilaterally. However, there was complete absence of sensory nerve action potential from the right lateral femoral cutaneous nerve of the right thigh. The contralateral side demonstrated a normal response. These electrodiagnostic findings provided objective confirmation of lateral femoral cutaneous nerve dysfunction consistent with meralgia paresthetica. Following confirmation of the diagnosis, the orthopedic surgery service recommended non-operative management given the minimal displacement of the avulsed fragment. The treatment protocol consisted of 6 weeks of protected activity with partial weight bearing and progressive range of motion exercises. Surgical intervention was not indicated, and at 2 months post-injury, the patient had returned to normal activities with minimal residual discomfort. This was a conservatively managed avulsion fracture of the anterior superior iliac spine, and the authors hypothesized that this hematoma influenced the lateral femoral cutaneous nerve, causing the subsequent meralgia paresthetica. Just some things that I learned on this. The lateral femoral cutaneous nerve is a pure sensory nerve derived from the L2 and L3 nerve roots. Anatomical studies have demonstrated this nerve is most susceptible to mechanical trauma at locations posterior, anterior, or medial to the anterior superior iliac spine. This is the location of the origin of the sartorius and tensor fascia lata muscles. While meralgia paresthetica most commonly results from entrapment at the inguinal ligament, alternative mechanisms have been documented. These include a traction injury following bone graft harvesting, direct compression by bony fragments, and compression by hematoma or surrounding tissue edema, like in our case. Anterior superior iliac spine avulsion fractures are injuries where the apophysis separates from the underlying iliac bone, typically occurring in adolescent athletes during sudden, forceful muscle contractions. The sartorius and tensor fascia lata muscles, which originate at the anterior superior iliac spine, pull the bony fragment away from the pelvis. These fractures represent about 30% of pelvic apophyseal avulsion injuries and are the second most common site after the inferior iliac spine avulsions. They predominantly affect male adolescents at approximately 77% of cases, with an average age of 14 to 15 years, occurring during a narrow window of skeletal maturation when the apophysis has not yet fully fused. The injury mechanism typically involves sprinting, running, or kicking activities, with soccer being the most commonly associated sport. Two distinct fracture patterns exist. Type 1 involves the sartorius avulsion. It is more common and is a smaller fragment typically displaced anteriorly. And type 2 involves the tensor fascia lata avulsion, tends to have a larger fragment displaced laterally associated with baseball batting. Most ASIS avulsion fractures are managed conservatively with rest and activity modification, and the outcomes are generally excellent. Surgical intervention is reserved for widely displaced fractures, typically greater than 20 millimeters, placement, or symptomatic non-unions. With appropriate treatment, athletes typically return to pre-injury activity level within 10 to 12 weeks. Okay, practice questions. 14-year-old male soccer player presents with acute right hip pain after kicking a ball during a match. He reports hearing a pop and experiencing immediate sharp pain in the anterior hip. On examination, there is point tenderness over the AIIS, or anterior inferior iliac spine. He had pain with resisted hip flexion and an antalgic gait. Radiographs confirm an AIIS avulsion fracture with 8 millimeters of displacement. Which muscle's forceful contraction is responsible for this injury pattern? A, the sartorius, B, the rectus femoris, C, the iliopsoas, D, the tensor fascia lata, and E, the hamstring muscle group. Correct answer is B. The AIIS serves as the origin and direct head of the rectus femoris muscle. AIIS avulsion fractures typically occur during forceful hip flexion with the knee extended, such as during kicking activities. The sartorius muscle originates from the ASIS, and the iliopsoas inserts on the lesser trochanter, and the hamstrings originate from the ischial tuberosity. Okay, question 2. 15-year-old female track athlete presents with right buttock pain that begins suddenly while sprinting during practice. She has difficulty sitting and reports pain radiating down the posterior thigh. Physical exam reveals tenderness over the ischial tuberosity, pain with resisted knee flexion, and pain with passive hip flexion with the knee extended. Radiographs demonstrate an ischial tuberosity avulsion fracture with 25 millimeters of displacement. Which of the following is the most appropriate next step in management? A, rest, ice, and protected weight bearing with return to activity in 2 to 3 weeks. B, immediate surgical consultation for open reduction and internal fixation. C, corticosteroid injection at the ischial tuberosity. D, aggressive physical therapy with early range of motion exercises. E, immobilization in a hip spica cast for 6 weeks. Correct answer is B. Surgical intervention should be considered for pelvic avulsion fractures with displacement greater than 20 millimeters, particularly in high-demand athletes. Ischial tuberosity avulsion fracture has a higher rate of non-union compared to other pelvic avulsion sites, and displacement greater than 20 millimeters increases the risk of non-union. Conservative management is appropriate for minimally displaced fractures, but this patient's 25 millimeter displacement warrants surgical consultation. Okay, question 3. Which of the following statements regarding the epidemiology of pelvic apophyseal avulsion fractures in adolescent athletes is correct? A. Females are affected more commonly than males. B. The ischial tuberosity is the most common site of avulsion. C. The mean age at presentation is approximately 14 to 15 years. D. Basketball is the most commonly associated sport. And E. The incidence of these injuries has decreased over the past 2 decades. Correct answer is C. Pelvic apophyseal avulsion fractures occur predominantly in adolescents with a mean age of 14 to 15 years old, during a period when the apophysis remains unfused and vulnerable to tensile forces. Males represent approximately 77% of cases, and the most common location for an avulsion fracture is the anterior inferior iliac spine. Soccer is the most commonly associated sport, followed by football and baseball, and studies have demonstrated that the annual volume of these injuries has increased significantly over time. Question 4. A 16-year-old male baseball player is evaluated 4 months after sustaining an anterior inferior iliac spine avulsion fracture that was treated conservatively. He continues to experience anterior hip pain with running and kicking activities. Follow-up radiographs demonstrate a prominent ossified mass at the AIS. Which of the following complications is the patient most likely experiencing? A. Avascular necrosis of the femoral head. B. Heterotrophic ossification with subspine impingement. C. Stress fracture of the femoral neck. D. Labral tear of the hip. E. Iliopsoas tendinitis. Correct answer is B. The AIS avulsion fractures have a higher risk of chronic pain compared to other pelvic avulsion sites, with approximately 14% of patients experience pain beyond 3 months. Exuberant callus formation or heterotrophic ossification at the AIS can result in subspine impingement, causing mechanical symptoms during hip flexion activities. This complication may require surgical excision of the prominent bone if conservative measures fail. Additionally, healed avulsion fractures may resemble neoplastic bone on radiographs, which is an important consideration in the differential diagnosis. Question 5. A sports medicine physician is counseling the parents of a 14-year-old gymnast who sustained an ASIS avulsion fracture with 10 millimeters of displacement. The family inquires about expected outcomes with conservative management. Which of the following statements regarding prognosis is most accurate? A. Surgical intervention is required for all ASIS avulsion fractures, regardless of displacement. B. Return to sport typically requires 6 to 12 months of rehabilitation. C. Approximately 97% of pelvic avulsion fractures are successfully managed conservatively. D. Strength deficits in the affected limb persist for at least 1 year following injury. E. Non-union occurs in the majority of conservatively treated cases. The correct answer is C. Studies demonstrated that approximately 97% of pelvic apophyseal avulsion fractures are successfully managed with conservative treatment. Conservative management includes rest, weight bearing, and progressive rehabilitation, with most patients returning to normal activities within 2 to 3 months. Research on strength recovery following non-surgical treatment shows no significant strength deficits in the affected limb compared to the unaffected limb at 3 months, with some patients demonstrating greater knee extension strength in the affected limb. Surgical intervention is reserved for fractures with displacement generally greater than 20 millimeters or symptomatic non-unions. Thank you.